All right, it is 5:30. We are going to go ahead and get started here. Good evening, everyone, and welcome to the 5th program in the Kansas and Missouri Cancer Research Highlights Series, hosted by the Masonic Cancer Alliance and the University of Kansas Cancer Center. I'm Ashley Spalding. I'm going to be moderating this evening's session. I am the Executive Communications Manager for the MCA. On behalf of the MCA and KU Cancer Center staff, we appreciate you all taking time out of your evening to be here with us tonight. Before we get started, I'm just going to run through a few housekeeping items. First, as a reminder, this Zoom session is being recorded. Second, all of our participants will remain muted throughout the program. If you would like to ask a question, please type your question in the chat box. We have dedicated times during the program where an MCA staff member will be posing your questions to our presenters. If you have any technical difficulties during the program and you're able to type in the chat box, please do so there. Finally, please be sure that any of your questions or comments that you do put in the chat box do not contain any patient identifying information. All right, we are going to kick off this evening's program with Dr. Gary Doolittle. Many of you know Dr. Doolittle. He is the Capital Federal Masonic Professor of Medicine in the Division of Oncology at the University of Kansas Medical Center, where he is also the Medical Director of the Masonic Cancer Alliance, Vice Chair of Education in the Department of Internal Medicine, and Assistant Dean for the Office of Medical Education. Dr. Doolittle has been a faculty member in the Division of Clinical Oncology at KU for 30 years and has a subspecialty interest in the treatment of malignant melanoma. Dr. Doolittle, we appreciate you presenting today, and we're excited to have you kick us off. Welcome.
Thanks, Ashley. I appreciate the invitation. And we'll set this up. How are we doing? Sharing adequately? Good evening. I really consider it an honor to be in front of you all this evening and to tee off the session on immunotherapy in the treatment of cancer. We've known for quite some time that the body's immune system plays a role in control of cancerous cells. But it's only been in the last 10 years that we've been able to harness what we understand about the immune response and use it effectively in the treatment of patients that have cancers. So if we think about immunotherapy in 2021, it has truly transformed the way we treat patients in the clinic. And as a melanoma doctor, if I had met with you 10 years ago, we had very inadequate treatments for melanoma that were based in chemotherapy. And we've known that the immune response, if triggered properly, could control melanoma. We know that these drugs help patients live longer. We feel many of our patients have better quality of life with these agents, very different than the quality of life that some experience through chemotherapy regimens. We can use them as single agents. There are combination therapies that have been brought to the clinic. We can add immunotherapy to surgical protocols, radiation protocols. There's a lot of study right now in combination treatments with oral agents. This slide also lists the different cancers that now have immunotherapy as an indication. We know that skin cancers in general, separate from melanoma, will respond to immunotherapeutics, but the list is really long and it's really changed significantly in the last 5 years. Bladder, breast, lung, endometrial, you see the list. And tonight I'm going to talk a little bit about the melanoma piece. You're going to hear about breast cancer and immunotherapy. You're also going to hear about lung cancer and immunotherapy. And we specifically chose these disease types because melanoma was the first cancer that was actually studied in the immunotherapeutic arena. And then breast and lung, it just makes sense because lung cancer is the #1 killer for men and women, and the incidence of breast cancer is so high. It made sense to have them part of our conversation this evening as well. So how does immunotherapy work? I was going to tee this conversation up and then talk about just one study in the treatment of melanoma. So how does it work? There are genetic changes in cancer cells that can make it harder for the immune cells to actually recognize them as abnormal. Cancer cells can have surface proteins that interact with and turn off the immune response. And we know that normal cells in and around altered cancer cells can interfere with how the immune system would respond or react. We're going to try to talk about this mechanism, and we're trying to break it down in terms that make sense for all of us. You know, immunotherapy stimulates T cells in the body, and it's the T cells, the activated T cells, that help the body fight cancer. And this has a lot of appeal in the patient arena. I mean, to think that your own body's immune system is being harnessed and revved up to fight cancer. The immune system has a mechanism in place that prevents it from attacking, or immune cells from attacking, normal cells. That just makes sense, right? If we had activated immune cells that were running around and attacking normal body cells, we would feel bad. We would be in a really bad state. And if you think of some patients that you know, or friends that you know, that have lupus or rheumatoid arthritis, those are diseases in which the immune cells are actually going after normal body tissues and resulting in that immune problem. This whole mechanism of controlling the immune response is quite sophisticated. We talk about just putting the brakes on the immune response so that normal body cells are not attacked. Now, if we could figure out a way to release the brake on the immune response, we could harness those activated immune cells to fight cancer. And that's really what has enabled us to have so many different options in the clinic now. This cartoon, I don't want to get too bogged down in it because it could be a little bit confusing, but I would tell you we're looking to activate T cells. And there's one protein surface, the CTLA4 there. When that binds to a protein receptor on a normal body cell, the T cell response is inactivated. But if we break that up, if we develop an antibody to CTLA4, as you see in the second panel, that will allow for activation of the immune cell. So one category of drugs that has hit the cancer clinic is the anti-CTLA4 drugs. So we're blocking an immune blocker to stimulate the body's immune response. And then the second mechanism is the Pd1 mechanism. And again, if you look at the cartoon, the middle panel, we see an inactivated T cell. And that's the case if the Pd1 receptor binds to a receptor on a tumor cell or a normal body cell. If we can break that, if we can block that from happening with anti-Pd1 antibodies, the T cell will become activated, and it's that activated T cell that allows for the cancer cell to be eliminated. So when we talk about immunotherapy and the treatment of melanoma, it's actually stunning. And sometimes I'm in clinic and I think our trainees really do not realize what a revolution this has been in the cancer care world. For patients with stage 4 melanoma 10 years ago, with widespread disease, only 5% of patients would survive 5 years. Now with that CTLA blocker that we talked about, and with anti-Pd1 antibodies, both of those drug groups allow for activation of T cells. Patients can expect to live longer and better. Ipilimumab was the first CTLA4 blocker that came to the clinic, and that was the first drug that showed improved survival in the widespread metastatic melanoma patient. Not too long after that, within a year, we saw anti-Pd1 antibodies that came to the clinic. These are highly advertised on TV. If you've seen commercials for Opdivo or Keytruda, those are both anti-Pd1s that have come to the clinic. And we know that in the immunotherapy world for melanoma, if we combine a CTLA4 blocker with an anti-Pd1, we get even better responses and even better outcomes. I wanted to share just one study with you. I think it really is a landmark study named Checkmate 067. I don't want to get too bogged down in the details other than to explain or to tell you that the CTLA4 blocker, ipilimumab, and the anti-Pd1 nivolumab were tested in this study. And there were 3 different groups that were tested: combined therapy with both nivolumab and ipilimumab, versus single agent therapy, nivolumab, versus single agent ipilimumab. When they first launched the study, I don't believe any of us felt that the outcomes would be so positive. And the study was actually designed more like we designed chemotherapy trials, because you were supposed to treat until the cancer progressed, or you treated until there was an unacceptable side effect. We now have 6.5 years of data that have been reviewed and just presented this past summer at the cancer meetings. And the investigators were trying to answer, how long will it take if the patient has a response? How long will it take for the disease to progress? Will patients survive? Will we improve survival with this? And how many patients will actually respond? Again, this is a typical graph for a cancer doctor, but I would like to break it down for all of us. The top part of the graph shows the survival of patients that receive both drugs, the CTLA-4 blocker and the anti-PD-1. And then the blue line on the graph, that's the survival of patients that just received nivolumab or the anti-PD-1 antibody versus the gray bar, which shows survival with ipilimumab by itself. And I think you can all appreciate that the combination therapy actually resulted in improved survival. At 5 years, half the patients with that were treated with combination therapy had survived, and the majority of those patients were on no therapy at the time. Their disease had gone in remission and they didn't require additional treatment. So we know that the combination of both drugs, stimulating the immune response in 2 different ways, resulted in marked improvement in survival for patients that had widespread melanoma. When I trained and when I started practice, we expected patients with widespread disease to live for 6 to 8 months. And now we know that at 6.5 years, we can expect 50% or more of patients to be alive. And of those, 3/4 of them are not receiving any additional treatment. Having said that, the side effects are significant. Basically, the side effects that we see with all immunotherapy are activated immune cells that start to go after normal body tissues. So we can see a rash, we can see GI problems, colitis, liver inflammation, adrenal gland problems, thyroid problems. That's the bad news in all of this. I think the good news is we're, as a community of cancer care providers, we're really becoming adept at recognizing the side effects as they are starting and trying to intervene with either holding therapy or intervene with an agent to counteract those side effects over time. So what has this done for melanoma? It's been a game changer, right? I mean, we've gone from a disease that had no active treatment seriously 10 years ago to a disease that will have patients that are living 3, 4, 5 years longer and better. A cure is kind of a 4-letter word in the melanoma world because we've never been able to tell patients that this was a possibility, but many of us believe that patients that get to 5 years and are off therapy have a real good shot at long-term survival and living through all of this. And we're so careful when we interface with patients because we want to make sure they understand the risks, the benefits, the reality of trying to treat this disease. But at the same time, there's so much more room for optimism and hope. Wanted to try to put a face to melanoma. These are all people that you probably know. John Mccain had multiple episodes of melanoma, and it's okay for me to talk about it because it's in the public sector, right? Clint Eastwood, one of the Kardashian sisters, Khloe. I think President Carter did probably more for the immunotherapy movement than any other American, in that he presented with widespread metastatic disease, brain metastases and liver metastases, had surgery, had radiation, went on Keytruda, and is in remission today. And I wanted to put the picture up of Bob Marley because I think we tend to think of melanoma as being a disease of Caucasians, and while the majority of patients affect the white population, this still occurs in the Hispanic group and in African Americans. Bob Marley had been to a physician multiple times, reporting the melanoma on his toe. And he was basically told that melanoma doesn't occur in African Americans. So we're really want to be really careful with that group. The last picture is a patient that I asked permission. I want to put a face to melanoma, and he's now 6 years out with widespread metastatic disease, including brain metastases, and he's doing quite well. With that, I will stop sharing and shift it back to Ashley.
Thank you, Dr. Doolittle. That was a great presentation. Sarah, do we have any questions for Dr. Doolittle from the chat?
We do not have any questions at this time, but if there's any that come up and you want to put them in the chat, do that, and Dr. Doolittle can address them there.
Terrific, thank you. And I do not see Dr. Huang on, our next presenter. Dr. Huang, are you on if I'm missing you? Okay, I do not see anybody trying to unmute. All right. Ms. Newsome, are you ready to go in place of Dr. Huang, or do you want us to have Dr. Sharma go and then you can follow her?
Whatever you all would like to do.
Okay, if you are ready, then I would love to introduce you if that works for you. I just don't want to put you on the spot too much because I know
I'm ready. The minute I knew the person before me wasn't there, I put my camera on. I'm like, okay, this is like TV news. You got to be ready because you don't know what's going to happen. We're live.
That's right. That's right. You're a pro. Well, we appreciate your flexibility. And we will have Dr. Huang on if he's able to join us. We will have him speak after Dr. Sharma. So it's my pleasure this evening to introduce our next special guest. We are honored to have Cynthia Newsome join us to share her cancer journey from the patient perspective. Many of you who are from the Kansas City area will likely recognize Ms. Newsome from 41 Action News here in Kansas City, where she is the midday anchor. Ms. Newsome is an award-winning journalist whose broadcasting career spans 30 years. She was originally diagnosed with breast cancer in 2011 and was later diagnosed with metastatic breast cancer in 2019. Ms. Newsome, we are thrilled and so honored to have you join us this evening, and we appreciate you sharing your story with us. Welcome.
Well, thank you so much. And I just want to say thank you, Dr. Doolittle. That is really great information. I really appreciate it. I appreciate all of the people involved in research, from the patients who get involved in the clinical trials to the researchers and doctors and all the people keeping all the statistics, because it really trickles down and translates into those 3, 4, or 5 extra years that Dr. Doolittle talked about. You know, I hope that grows to, 10, 11, 12, 13, 14, 15. But from a patient's perspective, I love that I'm sharing right now because it's Breast Cancer Awareness Month. And I've been very public with my breast cancer journey. And I love that Breast Cancer Awareness Month is right before November, which is Thanksgiving. All about giving thanks, being grateful, recognizing those amazing things that happen. And so I just want to say thank you to the University of Kansas Cancer Center, all the people that have been involved in this program, for my 41 Action News viewers who've been watching me and following me. I really appreciate you. My 41 family here at the television station. There are so many people that have been so critical and key just in encouraging me and loving me through this battle and this journey. And our doctors and our physicians are some of the most incredible people that we draw so close to, because we're really engaged and locked together in the battle. So we're not just going to an appointment and being told, here's what we're going to do. But I love that Dr. Sharma, my oncologist, who's also a researcher, just really involves you in the decisions, explains things so clearly, and that helps give you confidence and strength as you make decisions together. And so I just, this whole thing started with Dr. Jensen, who's over the KU Cancer Center. And I sent this note to him just thanking Dr. Sharma for just being so careful and so detailed and just having such passion and concern and care with every decision that's made. And it's not just her, it's a whole team of people. the ones in her office. It's even the schedulers, because when you have cancer, breast cancer, metastatic breast cancer, I mean, that's a lifelong journey. And so what it's like is trying to include cancer in your life, of course, because you have to for your treatment and all, but not to let cancer run your life. You're still able to live. And that's what's so valuable to me, is that, the scheduling, I'm still able to come on the air, do my show, and then I leave on the day that it's treatment and go get my treatment, or on the day that it's, time to get my new scans, my new MRI or CT. It's all scheduled either before or after I anchor the show. My bosses here at work are good with all of that. They're happy to, let me go and do what I need to do. And I mean, it's really been an amazing journey. And so I just want to again publicly thank Dr. Sharma and her team, for taking me and just embracing me in their practice and supporting me. So not gonna cry, but I do get a little choked up because this is so personal. It's about life, and those people that you appreciate, you really love them. You really love them. So thank you, Dr. Sharma. All right. I'm all better. I only have a couple more minutes, and I really want a couple things I want to say. And anybody who knows me, these are the three things that I always talk about in terms of being a breast cancer survivor, somebody still in the battle. I still have tumors. I'm still getting treatment. Is number one, that I always proudly, I'm never shy about saying that I thank my Lord and Savior, Jesus Christ. That's number one. My faith gives me strength and peace. This isn't easy, And so to anyone listening, lean on your faith. People are great, but there are private times when it's just you and your faith. And so lean on your faith. Number two, okay, my husband, Ed Newsome. You guys know him, you gotta love him. He's listening right now. Hi, honey, I love you. He's been amazing. We are gonna celebrate, seriously, our 20th anniversary is October 27th. And, he stood there 20 years ago and promised to love me in sickness and in health, and he did. And when I was diagnosed the first time with breast cancer and forever, he's always said, I'm not going anywhere. And I've covered stories where people have been left by people they thought loved them, but they couldn't stand for the battle. They couldn't stand in there because this isn't easy. And so I just be grateful would be some advice to those people who are loving you. Maybe you lost this or that person, or this, somebody doesn't help you anymore, but just remember those who did and who do help you. And so, I would always just say, see the good, and don't focus on the negative. Focus on those people who are loving you. For me, my husband, my champion, Ed Newsome, I love you, babe. And then I really did not think I would get emotional. It's just hard because when I think truly from my heart, if I just say it as facts, I can get through it. But when I think truly of the people I'm talking about, that's when it becomes a little emotional. So, and then number three, and everybody knows this, I really thrive on being able to make a difference, to make my life count. And it does. Everyone's life counts. But when you have found your passion and your purpose, and you're able to live that and accomplish it every day, that's an amazing thing. And so I just feel like my purpose and passion is making a difference. And by sharing my story about breast cancer, now metastatic breast cancer, I hope that I'm helping in this journey. This research takes money. It takes people committed to do it. It takes patients willing to participate. And I'm hoping that as I raise awareness on the air and privately in my circles, that the money will increase, more people will participate, and that, you know, we'll begin to have more research so people like Dr. Doolittle and others can do their thing and improve longevity for us. So those are the three things that I always promote as a breast cancer survivor. Again, you know, I was first diagnosed 2011, lumpectomy, chemo, radiation, survivor for 7 years. 2019, diagnosed with metastatic, and so I've been in the battle since then. I will tell you that on Friday, this coming Friday, I'm going to start a brand new regimen of a new drug for chemotherapy and a new drug for immunotherapy. And so it's kind of a new era, but what I've learned when I did a series of stories with metastatic breast cancer sisters is that along the way, the cancer kind of outsmarts the medicine. And so then you need to go to a new medicine or pause, like Dr. Doolittle said, or figure that. And so that's really basically what's happened to me. And Dr. Sharma can go more into it if she wants to. I always share the good and the bad. When my tumors are shrinking, I tell people, and when they're not, I let them know. And so I'm starting a brand new regimen on this coming Friday. So I'm going to anchor the show. I'm going to go in first in the morning and get all my labs and things, and then go back in the afternoon and start the new regimen on Friday. And I'm sure I'll be back on the air Monday. I mean, I've been able to tolerate the drugs really well, which I'm really so grateful for. So I don't know. I'm happy to answer any questions anyone has. You know, I may look fine and wonderful many times, but just like everyone else who's not even suffering from something as serious as metastatic breast cancer, you never know what someone's dealing with. You know, the heaviness of their heart or loss they might be experiencing, or disease and decisions that they need to make. So that's all I wanted to share. So I'm happy to take some questions.
Thank you so much, Cynthia, for your openness and your honesty and sharing all of your heart with us. I think I speak for everybody on this call right now, that you are truly an inspiration in your story and your outlook on life. I love the three things you shared with us, and the fact that you are just absolutely living life. You're a true example of not letting your cancer get in the way of your living, and that's fantastic. So we wish you absolutely the very best on Friday as you start your new treatment, and a happy anniversary next Wednesday. And I do want to direct you to the chat, because you've received a lot of love and positive comments in the chat when you have a chance to look at that. Sarah, do we have any questions for Cynthia in the chat right now? I know there's just a lot of positive comments for her.
Yeah, no additional questions, just a lot of nice comments. So thanks everybody for those.
Yes, and we are very thankful that you've had such a great experience at KU Cancer Center and with Dr. Sharma. And thank you, Dr. Sharma, for all you've done for Cynthia here as well. So with that, I think we are going to go ahead and have Dr. Sharma do her presentation. Dr. Huang has joined us, and so he will be able to present as well following Dr. Sharma. We will have time for questions for both. And if anybody thinks of questions for Cynthia in the meantime, please go ahead and put them in the chat. Dr. Sharma, just in the interest of time, I'm going to just turn things over to you right now.
Okay, thank you. I'm going to just share my screen here. Let's make sure it's showing up. There. Can you all see it?
Yes, that looks great.
Okay. Well, first of all, I want to thank Cynthia for such kind words and her courage for sharing her story, not only when things are going well, but when they're not going well as well, or as well as we would hope that they would be going. I also want to start out with saying a few years ago, a patient of mine with metastatic triple-negative breast cancer told me, I have cancer, the cancer doesn't have me. And that really struck me, that we as a community and as medical society really should pay attention to that we are treating the cancer in somebody, and that's the cancer doesn't define everything about that individual, and being able to live your life, do the things that you want to do while you're undergoing the cancer journey to the best of your abilities is very important. So shifting back to the topic that I'm going to cover today is immunotherapy for triple-negative breast cancer. And Dr. Doolittle covered so very nicely the rationale for why immunotherapy works. So we won't go into details for that, besides just covering a few salient things that pertain to breast cancer. So immunotherapy in breast cancer right now is active only for triple-negative breast cancer. Breast cancer is the most common cancer for women in the country, and of course in the states of Kansas and Missouri. And there are three main subtypes of breast cancer, and these subtypes are divided based on whether the cancer expresses hormone receptors or whether it expresses HER2 protein, or if it lacks both of those, then it gets put into this basket term of triple-negative breast cancer. So triple-negative breast cancer accounts for about 15% of all breast cancers when we look at it in all comers, probably accounts for a little over 20% if we look at African-American women. The conventional treatment for triple-negative breast cancer, whether it was early stage or metastatic, has been chemotherapy, and really hasn't changed much in 10 plus or 15 plus years. We've just been using the same drugs because we haven't found better chemotherapy drugs that improved outcomes, at least for those with non-metastatic disease. And in spite of our best chemotherapy, 25 to 40% of patients with non-metastatic disease will develop metastatic disease, and the survival after metastatic disease is fairly short, in the order of 12 to 18 months. That when we compare it to other two types of breast cancer, where the survival is in the order of 5-6 years. So clearly, what we have available in clinic is not optimal, and we need better ways to treat this cancer to improve outcomes. And immunotherapy had been highly successful in many other cancer types. It just hadn't made the progress in breast cancer yet. Because in general, for all breast cancers, it's not a very immunogenic cancer. So the immunotherapy wasn't really showing promise. But when we look at the triple-negative breast cancer, it's very different from the other two major subtypes of breast cancer. It shows high infiltration of lymphocytes in the tumor, expresses the immune marker called Pd1. Chemotherapy, which is the standard of care for triple-negative breast cancer, actually initiates many changes in the tumor and its microenvironment that make the immunotherapy work better. So all of these rationale led to the development of chemotherapy plus immunotherapy combination in triple-negative breast cancer. This is a little bit different than melanoma and even perhaps lung cancer, when immunotherapy as a single agent has worked. In breast cancer, it's typically in combination with chemotherapy. So for metastatic triple-negative breast cancer, two seminal trials led to the approval of immunotherapy chemotherapy combination. And these are shown here. I'm not going to go through the design and the data, but as you can see from the curves, the top curve for both of these is chemo-immuno combination, and the bottom is chemo, and the top curve is clearly doing better. And for metastatic disease, this combination is approved for patients whose tumor have this immune marker called PD-L1. And about 40% of patients with metastatic triple-negative breast cancer have this immune marker PD-L1 on their cancer cells, and that's where we use the combination of chemotherapy with immunotherapy. Even though we have this combination available, there are future research questions that are outstanding. Of course, what about those 60% of patients with metastatic triple-negative breast cancer that don't have that immune marker, where this conventional chemoimmunotherapy combination hasn't worked very well? What about when it works for a period of time and then it doesn't work anymore. As Cynthia mentioned, the tumor outsmarts it. Can we understand how it outsmarts it so we can work on those mechanisms and figure out a way for these combinations to work longer? And then biomarkers to predict the immune toxicity, because even though they're in metastatic setting, they're not as common, they do happen and require a fair bit of management, additional medications, holding of the treatment, etc. Now moving on to early stage or non-metastatic triple negative breast cancer. So this is stage 1, 2, and 3. There are many trials in the last 3 or 4 years that have looked at the combination of chemotherapy with immunotherapy in patients with early stage breast cancer. All of these studies have provided this combination preoperatively. So this treatment is given to the patient before they have surgery for their breast cancer. And at the time of surgery, the response to treatment can be assessed. I'm going to focus on just one study, which has recently led to the approval of chemoimmunotherapy in early stage triple negative breast cancer. And for early stage triple negative breast cancer, there has not been an approval of a new drug for 20 plus years. So this is a big stride for us and our patients. The schema of Keynote 522 study, briefly, what the trial did was enroll patients with stage 2 and 3 triple negative breast cancer and randomize them to receive a 4-drug chemotherapy regimen or the same regimen with immunotherapy called pembrolizumab. Following this regimen, the patients had surgery, and then they also continued either the pembrolizumab or not based on the arm that they were assigned. But the study found that there was improvement in response rate with addition of immunotherapy to chemotherapy when it was assessed at the time of surgery. And this response we call pathological complete response. And this improvement in response was seen in patients who had stage 2 disease or those that had stage 3 disease. So it worked in both stage 2 and 3 disease, and it wasn't just working for lower stage diseases. Most importantly, with the addition of immunotherapy to this chemotherapy, there was improvement in event-free survival. As you can see in the 2 curves, the curve on the top, the green one, has the combination of chemotherapy and immunotherapy, and the one on the bottom was chemotherapy alone. And based on this data, the combination of pembrolizumab and chemotherapy was approved by FDA last month for use in patients with early stage triple negative breast cancer. You all just saw this figure that Dr. Doolittle showed regarding the immune side effects. And what we are seeing, at least in breast cancer, the severe immune side effects that we see in patients with metastatic triple negative breast cancer were seen in about 5% of patients. But when we took the same immunotherapy and combined with chemotherapy to patients and gave it to patients with early stage disease, stage 2 and 3 disease, the rates of severe immune side effects went up to 14 to 15%. And perhaps it's because patients who don't have metastatic disease may have a more conserved host immune system. And thus the immunotherapy, as it works to kill cancer, is also promoting the body to attack self. In clinic, for us, it's really important to recognize these side effects and prompt management and early intervention, early modification of treatment is needed, as many of these patients now with curative disease will be getting immunotherapy. At KU, we've been running this trial called Neopat, and that is assessing a combination of immunotherapy with chemotherapy. The previous study that I just shared with you, the Keynote 522, that led to the approval of pembrolizumab, actually used a 4-drug chemotherapy backbone plus immunotherapy. So this is a 5-drug, 6-month regimen that's given before surgery. And it is an intense regimen. So the question we're asking in the Neopat study is, if we're going to include immunotherapy to be given before surgery, do we need all of that chemotherapy? Can we get by with 2 instead of 4 drugs? Can we get by with 18 weeks instead of 24 weeks of treatment and still attain the same activity of the combination, but with better tolerance, fewer side effects, and easier schedule of delivery of medications? So this trial is almost done accruing, and we hope to report it next year. And we appreciate all the support that we've received from our patients, our medical oncology providers, and the community in attracting patients to this study. There are other trials that address immunotherapy in triple-negative breast cancer that we've been actively part of. The SWOG 1418 study that enrolled nationwide almost 1,200 patients. We were part of it, and we enrolled many patients onto the study. And the study is also asking an important question for patients who've already had their surgery. They got chemotherapy and then had surgery, but this chemotherapy didn't kill all the cancer. And in those patients, can we add immunotherapy after surgery and lead to improvement in survival? This trial will report out sometime in the next year or year and a half. So in summary, for early stage triple-negative breast cancer, we now have immunotherapy approved in combination with chemotherapy. This combination improves response rates and survival, but may lead to overtreatment of many patients. The survival with chemotherapy alone is 80% in patients with early stage triple-negative breast cancer. And although it is far from what we would like for it to be, you can look at the other side of the coin and say 80% of patients don't need anything more than chemotherapy. It's just we don't know who those 80% of patients are. So right now, we are prescribing this combination to everybody. The immune side effects, especially the long-term toxicities, are going to be very important as we treat these patients with curative cancers that are going to live 10, 20, 30, 40 years. Many immune side effects like thyroid disorders, diabetes, effects on adrenal glands are permanent, and these patients have to take permanent replacement of some medication or another to combat these side effects. Of course, these drugs are costly, both in terms of financial costs and the patient costs in devoting time to come to cancer centers to get repeated infusions. And the question of how much do we need? Do we really need 5 drugs? Do all patients need 5 drugs for such a long duration of time to get the best benefit? So many ongoing trials are addressing these questions. What is the role of immunotherapy if you've had a complete response with chemotherapy? Should everybody take it up front? Should we wait to see where chemotherapy doesn't work? And that's where we would get the best benefit and risk-benefit ratio. Can we really de-escalate the chemotherapy backbone? And most importantly, biomarkers that can identify patients that are going to have preferential benefit from immunotherapy drugs. The biomarkers that have worked for other cancer types and for metastatic triple-negative breast cancer really hasn't worked for early stage disease. So as we design trials and look at research questions, we synthesize what we know about the cancer outcome with the standard treatment. What are the standard treatments and what are the outcomes? We combine that with what do we know about the biology of the cancer, the genetics of the cancer, the molecular dysregulations in the cancer. Then we go to what do we don't understand about all of this? What are our knowledge gaps? And if we fill those gaps, it would help us be more efficient in treating patients. And then we design trials, and the ultimate goal is to really improve survival after we finish these trials and study novel methods of treating. And I see the future of all our immunotherapy trials to encompass many important questions and put them together as we are designing the trial. Each one of them is critical in our ability to ask the right questions of the right patients in the right setting and be cognizant of the risks, the costs, the biomarkers. And so I'll leave you all with this last future-looking slide, and I'm happy to take any questions.
Thank you so much, Dr. Sharma, for the work that you do, the essential work that you do, and for sharing that work with us this evening. Michelle, are there questions for Dr. Sharma?
Yes, there's a couple. I believe this one was for Dr. Sharma. She asked, what was the name of the new drug? If not, I know Cynthia had mentioned a new drug, so I just want to make sure I was asking that to the right person. Great.
And it may be for Cynthia.
Yeah, I don't know what the name of it is, Dr. Sharma, so please go ahead and tell them.
So
I don't know. It starts with an S. That's all I know.
So it's an immunotherapy drug, but a different kind than what Cynthia was on before. It's called pembrolizumab or Keytruda. And what we've done is kind of switch the chemotherapy backbone also. So the immunotherapy is Keytruda, and the chemotherapy was a taxane-based chemotherapy before, and now it's going to be a platinum-based chemotherapy. And we made the switch because the cancer was outsmarting the treatment, but not in all areas. And we felt like if we could just fine-tune our approaches a little bit, that might let us allow this treatment to work longer.
Mhm. What does
And I think
platinum-based mean? I don't even know. What is?
So these are a class of chemotherapy drugs. Carboplatin and cisplatin are the two commonly used chemotherapy drugs for cancers. Carbo more commonly used for breast cancer, and both carbo and cis for many other cancer types. I see a question, what was the name of the drug that was recently approved? And that was, again, pembrolizumab that was approved for stage 2 and 3 triple negative breast cancer. It has already been approved for stage 4 metastatic disease, and we've been using it for a year or so. But the Keynote 522 study led to the approval of pembrolizumab in patients with curative triple negative breast cancer to be used in combination with chemotherapy before surgery. And the reason to do this treatment before surgery is you can assess the response at surgery and tailor the treatment that is given after surgery to the response. If there's a great response, you get less after surgery. If it's not a great response, there's other drugs that can be added after surgery. It's just we can't give all of it together. So for triple negative breast cancer, really the standard now is for most of these women to be recommended to have treatment before surgery because it helps us to tailor the subsequent treatment post-surgery.
Terrific. Thank you, Dr. Sharma. We are going to move on. I believe those are the only questions for Dr. Sharma in the chat. We're going to move on to Dr. Huang, who is our final presenter. We do have one question in the chat for Cynthia that I do want to make sure we get to at the end of the presentations. It's an important question around mental health. So we will come back to that. And now I'd like to introduce our final presenter of the evening, Dr. Chao Huang. Dr. Huang is a clinical professor of medical oncology at the University of Kansas Medical Center. He has a special interest in the field of lung cancer and head and neck cancer, especially in multimodality therapy, combining radiation with chemotherapy and immunotherapy. Dr. Huang, thank you for joining us this evening. We look forward to learning from you.
Thank you for the kind introduction and opportunity to present this. So I think my goal today is to talk a little bit about the immunotherapy in its use in lung cancer. And I think Dr. Doolittle probably went through the mechanism, and I may just use a little analogy in trying to explain this again, if anybody has any question. So these are the two researchers that we have to thank for the use of the immunotherapy that we have today. The gentleman on the left, he is Dr. Allison. He works at the immunology department at the MD Anderson. And Dr. Hongzhou is on the right. He is at the Kyoto University. And both of them are the Nobel Prize winners back in 2018. Based on the research that they did is what we have the immunotherapy today. So again, I think Dr. Doolittle went through this already. The way the immunotherapy works, or specifically what we call the checkpoint inhibitor works, there's two processes. There is normally in our immune system, we have the cells called the dendritic cells. And then the dendritic cells, we can make the analogy as being the judge. And the dendritic cell will recognize or tell the policeman, in this case, the T cells, by issuing an order to say, you need to go out and fight the cancer cells. So there's one signal that tells that, but there's a negative signal between this ligand called B7 and CTLA4. And when disrupted, when this signal is active, the order from the judge actually doesn't get transmitted to the police officer. And so the T cell or the police officer essentially doesn't receive the order, doesn't go out and do its job. The second step of the immune system is when the police receive the order, but when you go out to find in this case the bad guy, the police recognize the bad guy with this between the signal between the T cell receptor and this MHC complex. The MHC complex is basically sets of proteins that the cancer cells will exhibit, and it's basically an identity card that the police signal will look at it and say, this is the right person. But at the same time, you have this PD-L1 and PD-1 receptors interaction here. PD, again, stand for program death, and the PD-L1 program ligand expressed on the tumor cells. But when it's activated, it basically takes away that identification process and makes the tumor cell invisible to the police officer. So in this case, the police officer is unable to identify the bad person, and the T cell is unable to recognize the T cell. And so when you have the monoclonal antibodies like the atezolizumab, the pembrolizumab, which blocks this interaction, the police officer is able to recognize the bad guy, or the T cell recognize the cancer cell and mount immune response. That's sort of how this whole system is supposed to work. So again, you have the dendritic cell, which what we call the antigen presenting cells that issue a signal to the T cell, and the immunotherapy called ipilimumab inhibits that negative signal. Then the T cell gets activated. The T cell then goes to where the cancer cells are. The negative signal gets inactivated by the immunotherapy, the checkpoint, nivolumab, pembrolizumab, and so forth. And therefore, the T cell can then recognize a cancer cell. And so it's sort of like the judge issues the order, the police officers then go out, verifies the identity, and takes away the bad guy. So based on this principle, this immunotherapy has been hugely successful in treating not just lung cancer, but all the other cancers, as already mentioned by Dr. Sharma and Dr. Doolittle. Here we have what we call a 5-year survival curve in patients treated with immunotherapy. And not to make little of this, but you can see that at 60 months, close to 30% of these patients were or are alive. Well, you can say, well, this is not very impressive because the breast cancer, you have probably more than that. But just for comparison, if we use chemotherapy, less than 1% is alive at 5 years. So to have 30% of the patients being alive at 5 years, this is really a change in the way it's of the natural history of metastatic lung cancer. And so not only that, this is in patients who have what we call high PD-L1 expressor and low PD-L1 expressor. So that PD-L1 ligand that the tumor cell express, if it's high, indicates that the immunotherapy is able to work better. And you can see if you have more than 50%, almost 50% are alive at 5 years. So we are now seeing patients living 2, 3, 4, 5 years with metastatic lung cancer, which we didn't see before. And almost half of them are still alive at 5 years, which is really phenomenal. So not to, after it's tested in stage 4 disease, then the immunotherapy now has been tested in early stage disease already. This is the result, the long-term results for what we call the Pacific trial. This is a study in which patients receive combined radiation and chemotherapy. And then they were then randomized to receive this other immunotherapy drug called durvalumab or placebo. And you can see here that these patients that received durvalumab in blue curve, almost 60% of them are alive in terms of overall survival, almost here at the tail end at 60 months. And then in the same thing with probability of progression-free survival. So the chances that the cancer hasn't progressed at 4-year mark here is almost 50%. So this is truly remarkable that there's such a difference between the immunotherapy group versus the patients that did not receive immunotherapy. You can see the placebo group, they were almost half of them only are alive compared to the patients that received durvalumab. And so this has changed significantly how we treat lung cancer patients. And this is part of the standard of care in patients with non-small cell lung cancer stage 3 disease after receiving combined chemoradiation. And you probably heard this data already. The FDA recently approved this drug now to use as an adjuvant therapy. So adjuvant therapy is when we give it after surgery. This result was initially presented in June of this year. And this is the results of IMpower 10, in which patients with lung cancer between stage 1 and 3, they receive surgery and then adjuvant chemotherapy or chemotherapy after surgery to try to improve the results of the survival. And then they were assigned to either receive atezolizumab, which is another checkpoint inhibitor, for a year versus not receiving it. And as you can see here, the progression-free survival at 2 years and at 3 years, 57% of them without evidence of disease compared to 57. It's you can say this is not a huge improvement, but this is at least 5 or 6% improvement in terms of without progression-free survival. And so based on this information, this drug was just recently approved by the FDA to be given as an adjuvant therapy for non-small cell lung cancer after surgery. So where do we go from here? So, I mean, we can make an advances with clinical trials, and at the University of Kansas, we have several trials open. And so one of the trials that we're exploring here in stage 1 and 3A disease is this Canopy N trial, in which we're giving a combination of pembrolizumab and canakinumab before surgery. There's evidence that giving immunotherapy before surgery can reduce the size of the tumor, and perhaps that can improve the chances of patients undergoing surgery and outcome. So that's definitely being done. That's one of the research trials that we have at the University of Kansas. The other trial is this trial called the Alchemist trial, in which we're integrating immunotherapy with chemotherapy. And I think this trial may be changed since the approval of the atezolizumab as an adjuvant therapy. And we're also looking at the microbiome changes in patients getting immunotherapy, because there is evidence that the microbiome, the bacteria that's in the patient's body, can influence how the patients respond to immunotherapy as well as develop side effects. For stage 4 disease, we have several trials that's adding to the immunotherapy to see if we can improve on the outcome. For example, this trial here called the Keepsake trial, we're adding a compound called glutamine to see if it can change the metabolism of the cancer cell along with the standard immunotherapy and chemotherapy, and see if that can improve on the results based on the mutation presence of this mutation called NRF2 or the KAP1. This CEA positive is for patients who express CEA in their tumor. We have a trial in which we're adding a monoclonal antibody against the CEA plus immunotherapy, or plus immunotherapy and chemotherapy, to try to improve the response. And then we have other 2 trials for patients who have high expressions of that PD-L1 ligand versus low PD-L1 ligand to try to improve on the outcome. And we also have a study in squamous cell cancer. So a lot of things going on, because the results of the immunotherapy is certainly very, very good, but I think we certainly want to improve on that and try to find better treatments of patients with lung cancer. So with that, I'm going to stop and see if anybody has any questions.
Thank you, Dr. Huang. Michelle, do we have any questions for Dr. Huang in the chat?
We do not.
Okay, perfect. And I know we did have the one for Cynthia, so I would love to come back around to that one. Somebody asked, let's see, Cynthia, somebody asked about if you're willing to share some of the strategies that you use to manage your mental health through your cancer journey.
Oh man, there's just so many thoughts I have right there. It's very important to have just time to yourself, and do things that make you happy. Seriously, my husband and I love to travel, and so we just went on a trip. It was a great mental health boost. We went to a family wedding in Santorini, Greece. We just got back last week, and it was so beautiful and so just picturesque everywhere you look. So just surrounding yourself with beautiful things. You don't have to go to Santorini, but I do recommend it. It's a beautiful place. But surrounding yourself with moments where you're looking at nature and beauty, and you're relaxing and you're having positive thoughts. I think that's really important. The times of prayer are hugely important, and then I think doing good things if you have the strength, because sometimes, if you're down with cancer, when I first had my, initial breast cancer, I mean, there was no way, because of how sick the drugs made me, that I could get up and do things, but I can now. And so I do. And I make sure that I do. And honestly, it motivates me to get up and keep going. So having a schedule of things to do, of course, that helps with work. But also I have a nonprofit, Awesome Ambitions. And it's just a college and career readiness program for teenage girls in high school here in the metro. And, that motivates me to just be pouring into them and helping them find their way and discover their purpose and their passion for their lives, and kind of, give them whatever direction I can and help I can to get them on the road to achieving their dreams. And so that's something where I'm working with other like-minded women. And so, working with friends to do something positive is always wonderful. I love neighbors. And, just sitting outside sometimes on the porch and watching people walk their dogs and they stop and you talk. Those teeny tiny moments are just fun. They're just fun, and they're distractions, and you're not always just thinking about your disease and you may only have this long to live, or, you're just living now, and it's all going to count. It's all going to matter. And you're trying to make a difference, and the joy that brings helps me mentally. And so I hope that helps. That's pretty much, those are my thoughts about mental health. Does that help?
I think those were fantastic responses, Cynthia, for anybody who is a patient who living with cancer, or for the rest of us who just in everyday life. Those were great pieces of information to share. So we appreciate you opening up that way. Sarah and Michelle, do we have any other questions for any of our presenters?
Does not look like it.
Okay, perfect. Well, if we happen to miss your question, please be sure to reach out to us through the Masonic Cancer Alliance website, which is www.masoniccanceralliance.org. I want to thank all of our presenters for sharing your time and expertise with us this evening. Your presentations were fantastic and enlightening. We thank you also for the research that you all are doing to advance cancer therapies and to reduce the burden of cancer on so many people. A special thank you today to our special guest, Cynthia Newsome, for opening up and being so honest and generous with your time this evening and with your cancer journey and advice for others who are on similar journeys or possibly just starting out. So thank you so much for being with us this evening. We sure appreciate it. And finally, I want to extend a special thank you as well to all of our participants. We appreciate your time and joining us for these research series programs. We appreciate your insightful questions and your engagement throughout the evening. So stay safe, everyone, stay healthy, and enjoy the rest of your evening. Thank you so much.
Thank you. Bye.
Thank you.
Bye.
Thank you.
Thank you. Bye-bye.
Dr. Sharma and Cynthia, if you guys could stay on, that would be fantastic, please. Thank you.
Okay. Coming back on. Hi. Hi.
Hey, how are you doing? I need to see. Am I seeing you tomorrow, or is it Friday? I don't even know what I'm seeing you. Is it
I
Friday?
think it's tomorrow.
It is tomorrow. Tomorrow's Thursday. Yes. Tomorrow's
Yes.
Thursday, and then treatment. I don't know.
On Friday, I think.
Yeah.
Yes. Yes.
Yeah.
You're feeling better from the virus you had?
I am. And I took my last whatever that drug was, antibiotic.
Yes.
I took the last one at noon today.
Okay.
So
Okay.
yeah.
Good.
Yeah, I think my eyes are back to normal, and
Yes.
I'm feeling fine. So just a little bit of little tiny cold, but
Must have been
cough.
something in Egypt.
It must have been. Was it one of those camels I was on? I don't even
Yes.
know. Oh my gosh. But,
Possibly. Yes.
oh man. So
Joey, can go ahead and stop recording now, please. Thank you.
Sorry, we didn't